Hello, everyone, and welcome to the Didactic, the need for studying emergency medicine quality indicators through a sex and gender lens. My name is Nina Feinstein, and I'm an undergraduate researcher at Brown University in Providence, Rhode Island. It is my great pleasure and honor to introduce to you today's panelists who are leading experts and researchers of their fields in both quality outcomes and sex and gender in emergency medicine. Dr. Yinny Thomas, Administrative Fellow of the Baylor College of Medicine in Houston, Texas. Dr. Angela Jarman, Assistant Professor and the Director of Sex and Gender and Emergency Medicine at UC Davis in Davis, California. Dr. Allison McGregor, an Associate Professor of Emergency Medicine at the Warren Alpert Medical School of Brown University and Director for the Division of Sex and Gender and Emergency Medicine in Providence, Rhode Island. And Dr. Greg Buehler, the Vice Chair for Operations and Quality in the Department of Emergency Medicine at Baylor College of Medicine in Houston, Texas. They will now begin the presentation.
Thank you, Nina, for the introduction. I'm Eni, so thanks again for joining our talk. This is a very understudied area, so it has great potential for growth. Before we get started, I just wanted to lay out the land. We'll start by defining what quality measures mean, and then we'll provide a brief history of their development, discussing some of the challenges with their development, as well as thoughts for future progress. From there, we'll transition into sex and gender medicine and the reason it's important to study ED quality measures from a sex and gender perspective. There will also be some time for Q&A, as well as some thoughts for path forward. So first, in terms of quality measures, how do we define it? Based on CMS website, quality measures are standards for measuring the performance of healthcare providers to care for patients and populations. Quality measures can identify important aspects of care like safety, effectiveness, timeliness, and fairness. The first quality measure of ED care emerged in the early 2000s from the Hospital Quality Alliance work to measure hospital care for common conditions such as acute myocardial infarction, pneumonia, congestive heart failure, and stroke. Several of these hospital-based measures apply in part to the ED, but the majority of them focus on other areas of hospital care. Quality measures then evolved to include operational measures. An example of this that's still in use today is door-to-balloon time for STEMIs with the goal of within 90 minutes of hospital arrival. Next slide. So then several accreditation bodies then began to collect data on quality outcomes. In 2004, the Joint Commission and the Centers for Medicare and Medicaid Services, or CMS, collected performance data on these measures and publicly reported them. These were the first comparative data on ED performance that were available to the public and payers. And then in 2006, in preparation for CMS adoption of physician-level metrics, the American Medical Association's Physician Consortium for Performance Improvement developed a set of emergency medicine physician metrics. 6 of these measures, all of which related to chest pain, syncope, or pneumonia, were adopted into the Physician Quality Reporting System, which is CMS program to measure, report, and reward physician quality. Next slide. Then somewhere between 2007 to 2009, the National Quality Forum initiated 2 projects to evaluate and endorse measures of emergency care. Initially, the organization endorsed 22 standards for emergency care related to disease processes such as acute coronary syndrome, sepsis, and pulmonary embolism. Today, there are over 600 quality measures endorsed by the National Quality Forum. Some of these standards have been incorporated into measurement programs, such as those of CMS or private payers, but most have not. A challenge with adaptation is that many of these measures are not directly linked to a payer, government, or provider group. There has also been a number of other independent efforts to develop quality measures for emergency medicine, but mostly led by academic groups. Overall, ED quality care is covered by a patchwork of measures that neither align with national quality priorities nor reflect the full scope of ED care. Next slide. Then in 2012, in an effort to promote conversations between clinicians and patients and pressure for more transparency and accountability in healthcare, Choosing Wisely was created. The mission of Choosing Wisely is to help choose care that is supported by evidence, not duplicative of other tests, free from harm, and truly necessary. They have created a specialty specific list of things providers and patients should question. For EM, topics included on that list are things like appropriate utilization of CT for pulmonary embolism and appropriate antibiotic use in sinusitis. Next slide. But it was not until 2015 that the Clinical Emergency Department Registry, or CEDAR, was launched by ACEP as the first clinical quality registry for our specialty. CEDAR came at a time when the healthcare payment process was being transformed from a fee-for-service model to a value-based care one. Under the Medicare Access and Children's Health Insurance Program Reauthorization Act, a program called the Merit-Based Improvement Payment System, or MIPS, was created. MIPS redesigned provider payments around 4 targets, 1 being quality measures, 2, efficiency measures to reduce the cost of care, 3, meaningful use of electronic health records, and 4, clinical practice improvement activities. MIPS also used federal incentives and penalties to encourage providers to join qualified clinical data registries such as CEDAR. In addition, CEDAR has allowed the opportunity to measure outcomes, identify trends, develop measures from within EM that's specific to our practice. But as we all know, everything has come with a certain set of challenges, which Dr. Buehler will talk about.
Thank you, Dr. Thomas. Next slide, please. So what are the challenges that we've seen in the development of quality measures here within emergency medicine? I think going back to when it was started, and some of the first measures were very disease specific, as Dr. Thomas had mentioned. And one of those diseases that was adapted were pneumonia, and measures specifically around antibiotic timing for patients with pneumonia. And it was really based on poor evidence, and definitely had unintended consequences of overutilization of antibiotics. And I think that the failure of that measure, certainly for those of us that remember it about 10 or 15 years ago, developed some mistrust in the system and how these quality measures came to fruition. And then, as you can see with the rest of how other measures have been developed, there really hasn't been a consistent approach to it, right? It seems like every 2 or 3 years is what's the new flavor of the month, right? It was the initial measures are developed, adapted by CMS, and then there's National Quality Forum. Then and then we develop Choosing Wisely campaign. And now hopefully we've seen with the CEDAR, which has a registry and more of a systematic approach, at least to adapting measures for our specialty and specialty specific, hopefully some of those challenges are being overcome with that system through ACEP. Also, a lot of the measures were very disease specific. So, but we often see patients with, the patients that come to the emergency department have undifferentiated complaints, right? They don't come with their disease and with their diagnosis in hand. So a lot of those disease-specific measures only represent a fraction of ED visits. You definitely got into where we got to operational measures like timing, especially with the crisis of the ED overcrowding that we are experienced and continue to experience. And then it's kind of moved more toward utilization type metrics. So where are we going to go from here? Next slide, please. So what is the future? With the Choosing Wisely campaign and several of the CEDAR measures, you see utilization. So I foresee that will continue to be an area of continued measurement and potentially future measures as well for resource stewardship. I think there's, within the CEDAR measures, there's a population health measure. I think looking at comprehensive care and a holistic approach to patients, even in an emergency setting, there's going to be potential further development of more population health measures to see how are we contributing to preventive health and overall health and well-being of patients. I think quality measures of other specialties, right? I think this isn't just emergency medicine. Other specialties are also going to be developing quality measures. And I think we've all probably experienced when another specialty has something they need to improve upon and measure, it somehow comes back to, especially if the patient originated in an emergency department. So I imagine that may be the case with quality measures as well. I think we'll have to look at those carefully. If it is something that we can meaningfully impact the patient's care, potentially something to look at and adapt. And then two really important topics in healthcare today. The behavioral health crisis. I think seeing potential future measures specifically related to the quality of care that mental health patients receive in the emergency department, and then health equities. And should we be measuring these? Are we measuring these quality measures correctly? Are there sex and gender-based differences that should be accounted for and should be part of the measure versus just having one unified measure? And with that, I'll hand off to Dr. Allison McGregor.
Great, thank you, Dr. Bueller, and thank you, Nina, for helping us with the slides. So I think that's a really great entry into how, if we are continuing to develop these quality indicators, how can we use this tool and data to really start to decrease some of the bias that we see based on patients' biological sex and gender identity. We still find it very necessary to just at least define what those two things mean. And so when we say sex, we're talking about biological sex. We're talking about whether your sex chromosomes are XX or XY. There are some combinations that are very low incidence in the population, but in general, there's two basic forms. And these DNA, these sex chromosomes are part of every cell in the body. So they affect your heart, your lungs, the way that you metabolize medications, and so forth. Next slide, please. And then when we're referring to gender, we are referring to the social cultural role that that is imported on you when you declare what your gender in society is. And so it's not always binary that we're really appreciating now. And that's going to be something else we need to study. What does the effect of being non-binary have on your health and illness? But in general, when we're saying gender, we are saying, okay, how does that affect your health? And if you are a woman in society, then, lots of women wear heels because that's a cultural norm. And just think about what happens to the tendons of the midfoot getting stretched, and think about what happens to the nerves of the toes getting squished in. And so that's just one simple example. Where men, yes, this is an example of probably a businessman who often has a commute that he has to go to. But most of the time when I think of men, I think of work boots, and I think of the fact that our trauma rooms are filled because of the impact of that role that they have with hazardous materials in our society. Next slide. So, it's really interesting to have the viewpoint of emergency medicine where we see the entire breadth of the human condition, right? And we know that men and women are not the same, but this was not what our foundation in medical school taught us. Our foundation was that the sex chromosomes would determine what sex organs you had. Then you would have either ovaries or testes. That would determine what hormones you had, testosterone, estrogen, which would give you your secondary sex characteristics. Hair, breast growth, voice change, and that was it. And then everything else was fairly similar. Next slide, please. And so the truth is, when you're just like starting your shift, like look around and, and just take stock in the fact of like, what are you taking over? Why is it that 78% of all autoimmune diseases occur in women? Why is it that sudden cardiac death during exercise is like 30 times more common in men than in women? We now know heart failure mechanisms with preserved or reduced ejection fraction have sex-based physiologic mechanisms. Things like irritable bowel disease and migraines, all of these syndromes that we just assign women without really understanding the role of having a biological sex of being a female. Also, what does the hormone levels do as your relating to these conditions. So even though a disease occurs in both men or women, someone seems to have a greater incidence or a greater severity than the other. And it really has to do with looking deeper underneath the skin. Next slide. Now, why are we just really learning this today? And it dates back to how human subject research was performed. So males were the subject of research, most likely because at the, back in the Wild West, when we were doing research without institutional review boards, without human subject protection, we were discovering that we were practicing on imprisoned individuals. And then there were conditions that, like thalidomide, where a woman of reproductive age was involved in a study and then it was discovered to have teratogenic effects. And so the National Research Act, created very much needed resolutions, and that human subject protection needs to be at play, and that institutional review boards need to be part of the approval process. But what they also lumped in at that time was that women of reproductive age were protected. And so that really just changed the milieu at the time that we started to have much more evidence-based medicine. We started really developing our clinical trials on cardiovascular disease and stroke. And this was when it was really just determined on male animals and male humans. And so the NIH Revitalization Act was about 1993. And that's when the whole women's movement said, we actually don't know a lot about women's unique health needs. And so they said, okay, let's make sure that we include women in late stages of clinical trials. And then we realized that's not good enough. And the NIH, as of 2016, said that you must include sex as a biological variables throughout your study design and in preclinical cells and animal studies and in all stages of human clinical trials. That's because our understanding of mechanisms of disease at the cellular level is still required for us to understand how the physiological differences take place. Next slide. So colleagues and myself actually were curious. We wanted to look at how is emergency medicine doing with these variables? And we reviewed emergency medicine literature twice. Once in 2011, another time in 2017. The reason for the hoping for a big change was because in the middle of that was the consensus conference on sex and gender and emergency medicine research. And so we wanted to also see what kind of impact that has. And you can see that the categories that we looked at, the first one was gender reported, just even in the description of the subjects enrolled. And over 20% of the time, it was not even mentioned who was enrolled in the study. So they would just say 100 subjects were enrolled. We got a little better with this when we reviewed this again in 2017, but still, this is really the basic level that we need to be operating at. The very basic, and it's not good enough. And then we looked, is gender even included in the study design someplace? In the hypothesis, in the data collection, in the conclusion? Was it actually an independent variable? Most of the time, that means it was controlled for, which is not good enough as well, because controlling for it just implies that you are going to remove it and assume it does not have an effect. And then how much literature are we doing where it's actually the primary hypothesis? So this much hasn't changed. I will give a kudos to emergency medicine researchers, however. One of the reasons why we will probably never do this study again is because we are becoming very prolific researchers. And so we had almost triple the amount of manuscripts to review in just that time frame. So kudos to us. Let's start learning. Next slide, please. And so where we are today is when you discover a difference in sex, the whole next viewpoint where research is going is to look for what is the source of that sex difference. That is the crux of our future understanding, right? That's going to really affect our quality of research. So if you find that there's a difference between mortality between men and women in cardiovascular disease, is it environmental? Is it the fact that your gender is male or female and that imparts social cultural behaviors and biases? Is it genetic? Does it have to do with those coronary arteries themselves and what chromosomal complement is there? Does it have to do with the hormonal milieu, which we have really just ignored as too complicated, which now I think it's, our models can really handle this now. Is it called something anthropometric, which is our relationship to our desk and our screens? Who built those? What about car safety design? That has been really designed to fit a male crash test dummy. There still does not exist a female crash test dummy today. What has happened with that is that women who sit in the front seat have much higher significance of injuries and death, no matter if you're driver or you're the passenger. It's because women have wider pelvic girdles. We sit closer up to the steering wheel. Males have stronger neck muscles. These things need to be part of our understanding of our environment. And then the most interesting and the least studied yet is the gender of the physician, right? Or the gender of the researcher. Even in animal studies, this has been proven to have an important effect. So that interaction needs to be studied. This is going to result in science that is reproducible and responsible. When you look at social and medical sciences, the reproducibility of those two compared to all the other sciences is the lowest. And about 40% only of those scientific studies that we've published are actually reproducible. So we've been missing something. We've been assuming that we're alike enough. And that's not allowed us to generalize this evidence to our patients or to ourselves. Next slide, please. So if you look at cardiovascular disease, right, this is a great example to look at because there's a lot of data out there and we can now sort of tease it apart and look at the sex and gender lens. Why is it that it's the #1 killer for both men and women, but women are consistently having higher mortality rates than men? And so let's explore that. Next slide, please. Because doctors think that we're practicing evidence-based medicine already. We go to the literature, we look it up, we talk about it in grand rounds, we talk about it at morning report or when we're discussing things with residents, right? But what is our evidence based upon when 76% of cell-based researchers still do not know the sex of the cell they're studying? They don't know if it's XX or XY or how that affects the outcome or if their design, when animal models are still primarily male animals, when yes, we are enrolling more women than ever in our clinical trials, but we need to now analyze the data based on sex. Combining men and women in a study is no longer an effective way to really understand what is happening here based on the differences between men and women. Women make up over half the population. This is a moral issue that we need to really start to combat. And women are the healthcare deciders. So how generalizable is this evidence to our female patients? Next slide. And so we all know what we've studied is that this is what a heart attack looks like. The Levine sign, the clutching of the chest, a sudden blockage of a coronary artery. And that has been our basis for identification of heart attacks, of public health, of what the signs and symptoms are, and to our pattern recognition and to our treatment protocols. Next slide. But this is what a heart attack can feel like to a woman. Yes, she can have chest pain, and that's most common, but she's also more likely to have these other symptoms of back pain, nausea, lightheadedness, dizzy, fatigue, shortness of breath. I mean, if we're even lucky enough to consider cardiovascular disease as a cause for these symptoms for these women, our current diagnostic tests aren't really designed to study the way that women have heart disease. Next slide. So if we think about this in two terms, like one of individual and the other of systemic bias, let's look at the systemic bias that we have, okay? So if we look at this, like to the left of the screen, you have, these tools. Maybe there's apps that tell men and women what the signs and symptoms of heart attack feels like. When should you go to the emergency department? Who has actually done the data for that? Who's written those risk factors? Does that include sex-specific risk factors for women? Does it include the fact that the weight of the risk factors differ if you are a male or female? Let's look at things like even just ordering blood tests like troponin. We are now starting to embrace high sensitivity troponin. And what happened when that occurred was once you lowered the threshold of what was considered an MI, what was considered a positive troponin, they realized that we just included a lot of women. Women have smaller heart muscles. We're going to have different levels of troponins. We have different hemoglobins. Why don't we have different reference ranges depending on what your biological sex is? That's very important. Our stress tests have different sensitivity, whether you're a male or female. Think about cardiac catheterization. Cardiac catheterization is designed to detect the way that men have disease. Even when you look at the physiology of a plaque in a coronary artery disease, men have higher lipid cores compared to women. They have plaque rupture, which causes a blood clot, a quick thrombus that causes the expected result. And so women have more of a plaque erosion, less of stenosis, but still diseased artery. And so if you were to squirt dye in an angiogram, you're going to think that, that there's no disease in the women. Women have more diffuse disease. And just because you see dye go through doesn't mean they're not having vasospasm, microvascular disease, all of these alternate forms, maybe a dissection. We have to stop thinking of being 65 or older before we can even consider heart disease in women. Young women have it. There are different mechanisms that we haven't really embraced. For instance, the Y study, which enrolled all women, actually showed that 1 out of every 3 women had higher mortality rates, had a clean cath, clean angiogram, right? But that means that even if you're not fully stenosed, you still have mortality rates. And these women are the ones that are told that they don't have heart disease, that they have the chronic chest pain, that it must be psychiatric. It's probably their GERD. And so these are where our systemic biases are really at play, that we need to really look at this from the quality measures, from timing to references and so forth. Next slide. And then there's individual biases, right? We have been taught male-centric medicine. Not only that, we have had so many years of on-the-job training. We consider ourselves very skilled when we have pattern recognition, right? But think about that. What has that really done as far as bias? Has that been able to uncover individual bias, unconscious bias, or micro bias? These are the things that we work so hard to achieve, yet really maybe it hasn't been such a good thing when we look at the underpinnings of this education. So for each and each individual patient, stop yourself and think, what's the biological sex of this patient? What is their current gender identity? How does that affect their presentation? What tests should I order? What can I expect the sensitivity and specificity of those tests should be? Should I change the dosing of the medication? Should I give them different follow-up instructions? Make sure that you sort of check yourself each part along the way. Next slide. And I'll show you why that's really important, because it's not just the fact that we did not understand the importance of the differences between physiology between men and women. Because even when women acted like men in this study, this blew my mind, and it really made me think more about the bias issue here. So this is a study that looked at women that presented with crushing chest pain, an elephant sitting on their chest, and they had a positive troponin. even when that was the case and they didn't have atypical symptoms or they didn't have other expected things, women were less likely to receive evidence-based medicine. They were less likely to go to cardiac catheterization, and they had higher MACE rates and incidences. So we know that there is bias individually and within our system, that hopefully looking at it through the lens of quality indicators can start to peel away and maybe hopefully provide us with some tools. And at that point, I will stop, and Dr. Jarman will take over. I believe she's next.
Thanks so much. I have to make two small points. Number one is that we've done a lot of faculty development this week. And yes, I am the director of sex and gender at UC Davis, but I'm also a graduate of the Sex and Gender Fellowship at Brown. So Dr. McGregor really trained me and has been a fantastic mentor and sponsor. So thank you for that, and for demonstrating that this sort of stuff does work. And also, I just have to add, I'm ever the realist, and I want to thank Dr. Bueller and Dr. Thomas for kind of opening my eyes to the ways in which quality is helpful. So if I was hurt, to be perfectly honest, I don't have much background in quality until we started planning for this didactic. And I'm one of those people that have found quality lots of times to be sort of a misguided attempt, right? It's frustrating to have to click through a million things telling me to do this or that when that's not the right thing for my patient. But it's very clear to me that that's what I'm asking people to do when I'm asking people to provide evidence-based medicine to men and women. So as a sex and gender researcher, I'm constantly asking people to either treat women and men the same or to treat women and men differently, right? Depending on what the evidence shows. So I think this is the perfect marriage between quality and sex and gender, where we can provide individualized, personalized care for our patients to improve their lives and their mortality. So we're going to talk through some solutions now and ways to mitigate bias in terms of a systematic approach. So it's not all doom and gloom, but let's talk about some solutions, and then I promise we will leave plenty of time for questions. So next slide, please. So we're going to talk particularly about one study that came out of the Cleveland Clinic that used a checklist to improve care. So they were looking at STEMI. So we're going to continue to go on the cardiovascular trend here. And just note that there's a 48% higher relative risk of death for women who have STEMI compared to men. And that was from a big meta-analysis in the last 10 years. So this is a big problem. The increased mortality of women compared to men is a priority that's named by both the American Heart Association as well as the European Society for Cardiology. So it's well known that there are disparities here and that we're trying to figure these out. So this study was an intervention study, and they first looked at usual care, which was kind of the pre-intervention for patients that presented with STEMI. And as you can see, the number of women or percentage of women that received guideline-directed therapy was lower than men, and the amount of time between door to balloon was longer for women. As a result, women had much higher mortality. Let's go to the next slide. And you can go ahead and click through these points. These were just the results from their pre-intervention study. So again, women were less likely to receive, just back one, right? So they were less likely to receive the appropriate medications, and it took longer to get them to the cath lab. And then if you look at the back end, they were more likely to have all kinds of adverse events while they were in the hospital. They were more likely to bleed. They were more likely to have strokes. And then they had higher mortality in the hospital as well. So this group came up with a checklist intervention. We can go to the next slide. So whereas the standard care depended on people thinking, consulting, essentially the cardiology fellow and the ER doctor would get together, they would talk, they would decide, is this a STEMI, is this not a STEMI? You can go ahead and click through. That's just a graphical representation of what the last slide showed. And let's keep going. Good. So they came up with this protocol that really just streamlined everything. So what happened is the ED physician would activate the cath lab. There was no call, there was no conversation. The ED physician just decided, yep, this is a STEMI, activate the lab, and things happened. They created a STEMI safe handoff checklist that included things like the goal-directed medical therapy, so the administration of aspirin, the administration of other antiplatelet medications, the heparin, all of that stuff became sort of automated on a checklist. The immediate transfer, so this group had several different hospital systems. So if the physician in the ED decided it was a STEMI, you immediately were transferred. There was no delay. And they changed from a femoral to a radial first vascular approach in all patients for women and men. So the question is, what happened, right? What happened when we treated women and men the same? We can go to the next slide. So with that 4-step intervention, essentially everything improved. So if you look here, the percentage of women that received guideline compliant therapy improved, the door to balloon time improved, the mortality improved, excuse me, and let's go to the next slide. I'll show you all of this in a graphic representation. So again, this is pre and post intervention administration of goal-directed medical therapy. The top one here is just before they put in the sheath, and then the bottom one is completion of the PCI. So you can see, whereas initially there were significant differences between women and men, there are some slight differences, but nothing is significant after they introduced this checklist. And then next. And this is their door to balloon time. So post intervention, which was the 4-step protocol, women were slightly behind, 2 minutes slower to get their door to balloon time, but again, not statistically significant. And that was true at all of their centers. Next slide. Now, you might ask, what happened to all of those other effects? And you can go ahead to the next as well. So we'll highlight the things that are important here. To just take a step back for what we know about sex differences in cardiovascular disease, we know that women tend to be older, and we know that women often have more comorbid disease conditions. So some might argue maybe that's why they did worse. But if we look here in the control group, you can see I've just highlighted essentially the things that were significant. So women in the control group were more likely to have stroke, to have bleeding, to require transfusions, to die. And then if you can hit next, afterward, all of these things essentially went away. So if you look at the p-values and compare pre and post intervention, all of these complications actually resolved or improved when we treated women and men the same. So for me, that really takes some wind out of the sails of the argument that this is because the women were older or had other diseases. And then lastly, this is just a graphical representation of 30-day mortality for women compared to men. At the top, you see the control group there, where women, the all-cause mortality, and this is at 30 days, was almost 11%. And there's a huge benefit for women from the introduction of this checklist. So their mortality was still higher, but again, you see it's not significant, it's much closer. So what we want is for those lines to be the same. But we certainly see that we're getting there and making some improvements. Next slide. And lastly, you can go ahead and click there we go. This is just the last study we're going to talk about before we take some questions. And Dr. McGregor mentioned the importance of looking at both the gender of the provider as well as the patient. So we're here to say that sex and gender matter both in terms of the patient and of the provider, because there's a huge burgeoning body of literature showing that this matters. So this was another big paper. This is a database study out of Florida, but a really robust data set, over 500,000 patient observations, essentially showing that there was a mortality benefit for female patients of having a female identifying physician. And this is really pretty powerful. So if you look at this graphic here, you can essentially, it's labeled a bit confusingly. This is a binary, like if woman is 1, if not is 0. So this 0 row here, column, is men and 1 is women. But you can see the top line here is when you had a female physician. So both female and male patients did better when they had a female physician. But for women, this was really dramatic. So if women had a male doctor, their percent survival went down dramatically. So there was literally a survival benefit to having a female physician. They also found in this paper that that effect was mitigated with men that had taken care of more women. So more evidence, and I know I'm probably preaching to the choir that diversity matters and that we need diversity in our teams. We need to study sex and gender of our patients. We need to study not just the physiologic differences, but the biases that lead us to treat women and men differently, even when they do check all the boxes. So with that, I'll kind of stop, and then we'd love to hear, we have some questions, but we'd love to hear from the audience and what kinds of things you guys are interested in hearing about.
So one of the first questions that we got is, how do you envision leveraging quality indicators to improve equity and care for women?
Do you want to take that, Allison, or do you want me to?
I thought that, can you say, I thought that was more of a quality indicator question, but say it again.
How do you envision leveraging quality indicators to improve equity and care for women?
I can
Yeah,
start with that if you
more,
want.
yeah.
So, I mean, I think first of all, when we're developing the quality indicators, right? We need to, are we considering sex and gender at all? Are we considering any disparities or inequities in developing the measures? And if there are differences, are the measures that we're held accountable to, you know, incorporate those differences or not, right? I mean, I look at, you know, we went through the history of quality, right? And it started with disease-specific measures, right? It was the door to balloon, it was getting your aspirin, right? And if you look at the sex and gender equity work that doctors McGregor and Jarman presented, right? You know, look at all the differences related to women presenting with chest pain or women with MI, right? It's like we are back. We didn't do that work back when we developed all of those quality measures, you know, 20 years ago. But now now we're seeing those differences, right? So I think moving forward, we need to build that into how we study, right? Instead of controlling for sex and gender. So we can identify the differences. And as we develop quality indicators, why I think quality indicators is an important place for it is because you can see the evolution, right? It's merit incentive payment systems, right, are going to be based on quality, right? You know, those that are, you know, they're the payers are looking to measure quality and to pay for quality. So I think if the sex and gender equity is a part of the quality measures, that is, I mean, we've all had in the hospital, right? You have your quality committee that is so hyper focused on these measures, and you know, you have someone that might have sepsis, and someone's coming over and asking you, "Have you done this for it?" Right? That they're investing in that because why? Because it's tied to reimbursement. So I think if we can get it there, I think you'll really see the needle move on equity.
I would also just add that this is inextricable inextricable from the research. So all of the comments that Dr. McGregor made, you know, when we institute a quality measure, we need to evaluate it, right? Does it actually improve quality, and does it improve quality equitably? So whatever the checklist is or thing that we're doing, these studies are really important because if it improves mortality for men but not for women, then that's not an equitable metric, right?
Thank you. And now moving into questions in the chat. If anyone has any, feel free to put them there. Well, another one we have is, were quality measures derived in gender equitable ways?
I think Dr. McGregor and Jarman already hinted at that. And the short answer is no, right? Take the heart score, for example, which gets factored a lot into some of our quality measures. It predicts major cardiac events, but if you read the original paper when it was developed, you'll notice that the study did not consider sex and gender differences in terms of presentation, symptoms, myocardial injury, or EKG changes. And we know that women have differences in EKG morphologies in terms of the QT interval, PR interval, or ST segments. So this is an example where we can really redefine the heart score and use it in a better way to predict dose women who will have a MACE event. But yeah, ultimately I agree with Dr. Beeler. We need to tie this back to incentives in some sort of way to help with compliance as we move the needle towards equity.
And just to add to that, which I totally agree with, of course, is, if you're, like you said, the heart score, we all, learn it because our departments tell us that this is, the new way to decide whether someone's going to go to the chest pain unit or inpatient. And then we're just like, oh, okay, this is the new way. But if you actually go back and look at the literature with the understanding of who was enrolled? Did they actually design this to look for differences? Were women even, part of the study? Was it sex-based analysis? So I think in general, what we really need to really make sure that we do in our future, our journal clubs, when we are presenting papers, is to always look at who was enrolled, because that's who it's going to be generalizable to. You can have a great study. Quiet. You can have a great study that enrolls all men. I take care of men. I'm going to want to know what that is. But in the title, say this is a great study on men, and so I know who to generalize that result to. That's the thing. So if we're going to use this literature for both men and women, we need to make sure that we design it to determine if there are important sex differences. There may not always be, but we can no longer assume that there isn't.
Thank you. We do have a question in the chat. Is anyone in the policy world working on this yet?
I'll just add the first part of that question, working on kind of next steps. So like we have all this research showing the disparities, but how do we convince all these organizations to integrate these into the metrics so hospitals actually are responsible for reporting and improving these metrics by sex, gender, and then other factors like race?
I think it's a fantastic question. I don't know if I don't know the answer. Working in the advocacy space for this for so long, it takes a lot. I think having at least the NIH use this as a quality, as like a measure of excellence of research, really sets the stage. But even things like the FDA, they can't mandate that pharmaceutical companies take sex and gender, and they can only suggest or promote. So this is a great new space that's new to me as well, that I would love to be on these committees, or just be invited to these committees to showcase the importance of these. So I think spreading the word in any way that we can be helpful, but from policy down, that takes a lot, and I'm open to suggestions.
Thank you so much.
No,
Sorry.
I wanted to echo, I feel the same way. This is a really great question. I don't know the answer, and I'm really curious to hear from the quality people. But it seems to me we've kind of like started to fix the front end of it, where we're now addressing sex as a biological variable in grant applications, right? So the funders have started to pay attention to this. So we're kind of fixing the front part, but what about the back end? And how do we get people to pay attention to that?
Yeah, and I think I would agree with that, and I also think awareness is an important step, right? And as Dr. McGregor had said, through policy, through quality, and I myself learned quite a bit working with Dr. McGregor, Dr. Jarman, Dr. Thomas. Dr. Thomas is our administrative fellow, so and meet with her regularly. So I've learned so much from her. And I think an important point is this isn't a problem for women to solve. This is a problem for all of us. very similar, in this, we have, social injustices in this country, right? That's a problem for all of us to solve. And in this case, right, these health inequities, this is not just a problem for women to solve. So, we need, I'm sure if we look, through the participants, right, it's going to be a majority women, right? We need those that identify as male and female to be in this together.
Thank you
Can I
so
just
much.
add, so number one, yes, I agree so much. But one of the sort of principles of sex and gender is that this is good for everybody. And so that paper I talked about where they did the Cleveland Clinic study where they instituted the checklist, men's mortality improved too, just women's improved disproportionately more. But standardizing these things and studying these things is good for everybody.
Perfect. Thank you so much, everyone. I think that's all the time we have for today. But we appreciate your attention and questions, and feel free to contact any of the panelists as shown here. If you have any questions, thoughts, or ideas for future collaborations on projects. Thank you so much and have a great rest of your day.